thank you again for the platform, and thank you for everyone who's taken their time to join us. It's always good to continue our education and not just remain with what we learned when we were still studying. So today's topic is also one of topics that is very dear to my heart. Like Dr. Makakula has mentioned, that it was my MEd study. So I will be quoting Dr. Masina in this presentation. So trial of labor after cesarean section, to do or not to do, that is the great question. So cesarean section is a common gynecological procedure which is used to deliver the fetus through the anterior abdominal wall. It was devised as a life-saving procedure, and it dates back to the 1500s. However, because of certain issues like unsafe anesthetic, unsterile conditions, mortality and morbidity was very high. Almost nobody survived the cesarean section back in the 1500s. But now with increased in safety, the safety has improved, and most people don't even regard the cesarean section as a major abdominal procedure. And we have seen a steady incline in the rise of cesarean sections. So from the around 1976 to the 2015, there has been a rise from 15 up to more than 30% of cesarean sections. And this has led to concern because obviously with the increase in cesarean section rate, there hasn't been seen to have an added maternal or fetal benefit. And with increasing cesarean section rate, we have seen also an increase in the maternal morbidity and mortality that is related to cesarean delivery, which then goes back to the ideal rate that is suggested by the WHO, which is set at 10 to 15%. So beyond this rate, the WHO does not find any benefit in doing further cesarean delivery. And hence, we have now come to find strategies to try and decrease rates of cesarean section. And that is where trial of labor or VBAC comes in. So just to clarify the differences between TOLAC and VBAC. So trial of labor after cesarean section basically is just that. You are trialing out labor after previous cesarean delivery with an opportunity to achieve a vaginal delivery. So VBAC is vaginal birth after cesarean section. This is the end result of a TOLAC. So a person who's undergoing TOLAC has had now a successful vaginal delivery. But often you find that these terms are used interchangeably. So also in this presentation, you will find that I switch between the terms without referring back to this. So there's this old saying, once a cesarean, always a cesarean. Is this true? So this is also one of the things that have led to an unnecessary increase in cesarean section, because we find that once a person says, I've had a cesarean delivery before, we fail to further explore the history and the circumstances surrounding the cesarean section. And then we just find it easy to move on and then say, oh, you then can't deliver normally. And we go on to do a repeat cesarean section. So the common current reasons why cesarean sections are performed: previous cesarean delivery accounts for 27 up to 54% of elective cesarean cases. Obviously, in the public sector, it's the lower end, but where you get to a private sector and more affluent countries, the rates are much higher. In Brazil, you find up to 80% of cesarean of deliveries are by cesarean section. There is now also this phenomenon of maternal request, where people are now labeled that they are too posh to push. You'll find that patients complain that they feel labor pains. We want the birthdays of our children to be on convenient days. We want to align them with whatever anniversaries. The gynae as well. As I'm sitting here, I have a patient who's fully dilated. So if we had planned an elective cesarean section, we would have done this nicely during the day. I wouldn't be sitting with 1 foot out of the door. Then there's also maternal comorbidities. There's a tendency that when a woman has any comorbidity, regardless of what kind of comorbidity it is, there is a higher tendency to lean towards delivering the lady by cesarean section. This is one of the places where we can make a difference, where we have to teach great CTG interpretation skills, because also you find that incorrect monitoring or incorrect interpretation of CTGs leads to unnecessary cesarean sections. There are unavoidable cases like malpresentations, but also we need to know which forms of malpresentations are deliverable vaginally or are not deliverable vaginally. Macrosomia, this definition also tends to become fluid, where macrosomia per definition is a baby that is more than 4.5 kilograms, but you find that people that have babies more than 3.5 kilograms, there is a higher tendency to lean towards delivering by cesarean section. And then there's also genuine indications like placental insufficiency and inability to abduct or a contracted pelvis, etc. So can anybody have a trial of labor? So our maternal care guidelines are very clear on the criteria that need to be met before a lady can be offered trial of labor after cesarean section. So on history, if you know that, or you've got medical records and you know that the lady has had a single lower segment transverse uterine incision, then that lady can be offered trial of labor. Often we don't know whether the lady has had a classical or a lower segment incision. You can try and tease that out from history. However, the scar on the outside does not necessarily always reflect of what is happening inside the uterus. So anybody who's got a singleton pregnancy, however, the Americans are also not very keen on sectioning any person who just has a multiple pregnancy just simply because they've had a C-section before. So, however, our guidelines are very strict. We stick to only a person who's got a singleton cephalic presentation. Again, fetal weight. So in South Africa, we find that our average birth weight is much smaller than in higher in the European and American countries. So our fetal weight cutoff is a fetus that is less than 3.5 kg. You can trial that for labor, whereas with the Americans, they quote that a fetal weight above 4 kilograms will then not be given a trial of labor. Obviously, if there's no other contraindications to vaginal delivery, like placental abnormalities like a previa or pelvic abnormalities or abnormal lies. Maternal obesity. So what we know about maternal obesity, particularly a BMI of more than 40 kg per meter squared, is that it is inversely proportional to achieving success of a VBAC. However, this is not strictly a contraindication to trialing of labor. So if you have an obese patient, you must look at all other factors that are associated with that pregnancy and not just base it on their obesity, that you don't want to do a TOLAC for them. Because also remember, an elective cesarean delivery is not harmless. So in an obese patient, all those major complications that are associated with obesity, they're difficult anesthetic, they're difficult procedure, but also you don't want them to also develop an emergency in the middle of the night when you often have least experienced staff. So with obesity, it's often a catch-22 and shared decision-making with the patient and taking into consideration all those things, the environment that you find yourself in, before you make a decision whether you can allow a patient to have a TOLAC or not. Maternities are often inclined to have cesarean sections, elective cesarean sections. However, it is not contraindicated. There are some conditions that are not contraindicated for trial of labor. For example, hypertension. If the patient does have hypertension without any other complications, they can safely undergo trial of labor. Maternal age, advancing maternal age as well has an inverse relation with the success of achieving a VBAC. We tend to find that the older the lady is, the more inclined we are to offer them an elective repeat cesarean delivery for fear that it's often a precious pregnancy. We don't want any further complications or anything go wrong, because we know that once you are over the age of 40, your chances of getting pregnant are decreased. So what are the benefits of having a successful trial of labor with a VBAC? So if you do succeed in achieving a VBAC, you avoid major abdominal surgery. You have less infectious morbidity. There is no scar that can bleed, that can be infected. There's no risk of other respiratory complications. You do have less blood loss if you achieve a VBAC. There's also rapid recovery. So if you're admitted in labor, most of the time, the next day, you are well on your feet, you are able to take care of your newborn. There is no recovering from major abdominal surgery with its ongoing pains. You've got decreased risk of venous thromboembolism, which is higher in people who have cesarean deliveries. And also, because you avoid a major abdominal surgery, therefore you avoid other surgical complications like adhesions and injury to neighboring organs. Also to note, those who want to have larger family sizes. So if you have a VBAC, women who are motivated to have a trial of labor after cesarean section are those who often want to have more than 3 children. So they often want to have the opportunity to continue having more children, because there is unfortunately a tendency to counsel against having more than 3 cesarean sections because of the known complications that come with multiple scars on the uterus. And because of this, there is decreased future complications of placenta previa and placenta accreta spectrum. So what are the maternal risks that are associated with elective repeat cesarean delivery and in patients with trial of labor in term patients? So this is a table that has been extracted from the American guidelines. So as you can see, women who then go on to have an emergency Caesar, there is slightly increased infectious morbidity with surgical injury. In women who have an elective repeat cesarean delivery, there is slightly higher increase in surgical injury in those that end up with an emergency cesarean section. There is increased rate of blood transfusion in women who have a trial of labor, and also there is an increase in risk of hysterectomy. So uterine rupture is the main reason that we are scared of doing trial of labor after cesarean section. So uterine rupture, if you look at it with an elective cesarean delivery, it is not a completely, we do not completely avert the risk of having a uterine rupture. There is still a small risk. However, with a trial of labor, the risk has increased, albeit still small, less than 1%, but it is markedly increased to 0.71% to 0.9%. The maternal death rates, cesarean delivery is associated with increased maternal morbidity and mortality. And also, as you can see here with maternal death in elective cesarean delivery, it is still higher than in women who undergo TOLAC. Neonatal morbidity as well, there is antepartum stillbirth that is increased in women who have elective cesarean delivery. However, decreased risk of stillbirth in intrapartum stillbirth in women who undergo TOLAC. HIE is also increased in women who have TOLAC, and also a slightly increased perinatal morbidity and mortality as well. NICU admission, there is no real major difference, but if you look at the upper end, those who undergo TOLAC, there's slightly increased rate of neonatal admission. In terms of respiratory morbidity, also TOLAC patients do tend to have increased respiratory morbidity. Those that are born by elective cesarean section tend to have higher rates of transient tachypnea of the newborn. So can we predict success of trial of labor. There are multiple or various tools that can be of trial of labor. One of the more common or frequently used tools is the one that is designed by the Maternal Fetal Medicine Unit Network. It's an American model that basically can be administered or can be assessed at the first antenatal visit. It looks at various factors for the woman, and it said that this tool does correlate with the rate of success of achieving TOLAC. So it looks at the maternal age, the BMI, if the previous indication for the previous cesarean section, was it labor dystocia or was it a non-recurring indication like a breech presentation, if there's any comorbidities, and then you calculate, and then at the end of it's basically like an app. At the end of the calculation, it gives you a percentage or the likelihood of how likely you are to achieve a VBAC. You can also use what we call the FLEM model. It's also found on MDCalc, which is something that is quite nice because most people do have this app on their cell phones and you can do quick medical calculations. So there's a lot of information on MDCalc. I'm not promoting MDCalc, but it's one of those things that are quite, it's a handy tool. So this one you use at admission of labor of the patient. It also looks at similar factors like the maternal age, if the patient has had a vaginal birth before, if there is, what was the reason for the previous cesarean section, the cervical dilatation and effacement at the time of admission. And it also gives you a score at the end, and it will tell us the higher the score, the more likely you are to achieve a VBAC. So these tools have been found that they do correlate with the success of VBAC for individual patients. So the success rate of VBAC in European and American study, it has been quoted to be 60 to 80%. However, this varies wildly in the different regions of the world. In Asia, it was found to be about 54%. And in African regions, and most particularly in South Africa, now my study found that the success rate for VBAC in our institution was about 36%. There was another study that was done in the Pretoria region. It found the success of VBAC rate to be about 42%. So we have much, much lower success rates than in the European countries. And women with African ethnicity have been found to have lower lower VBAC success rates internationally. So that must be taken into consideration when we counsel our patient. We also use a very strict protocol, which basically puts a limit on how we manage the labor of a woman that is undergoing a VBAC, just to avoid complications as well. And partly that is the reason why we tend to have lower success VBAC rates. However, we know that the labor curve or the pathogram should look similar in women who are undergoing VBAC or who are undergoing a trial of labor compared to those who have never had a cesarean section before. So that is one of the things that maybe we can look into to decrease the rate of failure of trial of labor. So basically this table was taken from my study, which also basically shows that the rate of VBAC success or success of trial of labor. If you've had a previous cesarean section, we're just going to jump through the demographic and just look in the middle. If you've had a previous a successful VBAC, you have the highest chance of achieving success with your next VBAC. It's about a 66% chance, which has been the highest. And also, the more advanced you are admitted in labor, the more likely you are to achieve a VBAC than if you are admitted in early labor. If you can see those that were admitted in early labor, only 39% of them achieved VBAC, and up to 73% ended up with an emergency Caesar for failed VBAC. So this again goes back to looking at our labor curves, labor progression curves for patients that are undergoing trial of labor versus those that have not had a cesarean section. We have a much lower tolerance to cutting than when a person has not had a cesarean section. The jury is still out. Looking at what we have seen, individualized care should be offered to each patient. It's not a one-size-fits-all. Previous vaginal delivery or a VBAC is the most reliable predictor of having a successful trial of labor or VBAC. Although there are risks involved, trial of labor, if done in the right center, it is a fairly safe procedure. The absolute risks are very low. Cesarean section is still a major abdominal procedure, and it should remain reserved for medical indications. And we know the consequences of multiple uterine incisions, especially the placenta accreta spectrum and placenta previa. Those should be taken into consideration when we counsel patients for trial of labor, because when they do happen, albeit that they are rare, they do have a very high morbidity and mortality risk. And remember to offer non-directive counseling, and patient autonomy should be respected at all times. So unfortunately, I have not given you the answer whether to do or not to do, but I'd like you to look at all the points that we have spoken about and take that into consideration when we counsel patients for labor. Thank you.
Awesome. Thank you so much, Lihle. It was quite comprehensive and very, very informative. It's always nice, you know, when we have a speaker that presents their own work and which is quite relevant to the topic they are talking about. So thank you so much. In terms of in private practice, obviously hospitals are different. I'm just going to ask this because also you primarily in private practice there. What is sort of the trend, you know, in your area there of patients with previous Caesars and offering them trial of labor? Or your opinion generally
about
around
my,
the
I'm going to speak about my practice. Ne? So
yeah.
I work mainly at Mitchell's Plain. We know Mitchell's Plain is in the Cape Flats. It's very notorious for high rates of crime. So unfortunately, what happens is the staff also is not on site after hours in theater. So when I look at my individual circumstances, I've had a couple of people who would like to try VBAC, but I've looked at my circumstances. It takes me about an hour and a half to 2 hours to organize an emergency cesarean section, which is not ideal. And if you have a person who is deemed to be high risk undergoing trial of labor, who needs constant monitoring, if you need an epidural, you need to be able to put one in. Unfortunately, it does not work out for them. But most of the time, women are really, really afraid of labor pains. We know that it is one of the most painful conditions that any human can experience. So those that want to try, most women just request an elective Caesar before even going for trial of labor.
Thank you so much. And you know, I remember there was one tweet that trended sometime last year, and I always quoted it at one of the antenatal classes that we do, where, you know, there was an assertion that a Caesar basically rewards the doctor more, whether it's financial benefit or what is your opinion on that? For instance, there's this general belief that the doctors would rather do a Caesar because they will be paid more. And I think I can speak like that because we're all healthcare workers here. So your opinion on that, please.
Okay, Philly, I think maybe we must just let them know that for people like us who work in the rurals who don't have co-payments we get
Yeah.
paid exactly the same for doing a caesar and an NVD. So I think we must try and dispel that misconception. However, I think people need to be educated as well, because there are some people who are very what can I say? They are very stringent about their beliefs. There are people who are very anti-Caesar. There are people who are very pro-Caesar, to a point like those that are too push, where you have a very low-risk woman with a small baby with absolutely no reason why they cannot go for trial of labor. We've got good analgesia systems on board, but they feel that nope, they'd rather go for an elective Caesar. And then you have those that definitely want to go for vaginal delivery, even if it kills them. I know, for example, now we are all on social media. There are these digital doulas that have now started trending. I know of a particular lady, she's a previous Caesar ×2, and she's now spreading the gospel that don't let the doctors lie to you. She's had a VBAC after she's had 2 Caesars. And unfortunately, that kind of misinformation to the public can be dangerous, because people unfortunately look up to celebrities and influencers, and they take their word as gospel, and they forget to look at their individual circumstances and take what their doctors say, or educate themselves more about their own condition rather.
Awesome. Thanks, Lihle. There's a few questions on the Q&A. I think there's one on clinical pelvimetry. Do we still do this? As far as I know, we no longer do clinical pelvimetry. The head basically will just find a way in the pelvis. If it doesn't, then it's
yeah, so basically we don't do clinical pelvimetry. Like I said, the best predictor for whether you can deliver normally or not after a cesarean section is if that pelvis has been tried by labor and has delivered before, because the pelvimetry has been found is quite invasive, it's quite inaccurate, and it's not reliable.
Yeah, and in terms of the prerequisites for a facility to be able to offer VBAC, I think there's that whole criteria you mentioned from the guidelines, and there's a participant, Chinenye Akukalia. They're asking what facilities are needed to be in place for monitoring of VBAC.
So patient on VBAC, for monitoring, you do need once they're in active labor, you need to put them on continuous fetal electronic monitoring. You need to be able to have a good patient to nurse ratio, because there's no point in putting somebody at the back of the hospital and there's no one actually checking on that. So also you need good patient to nurse ratio. You need to have a blood bank on site. You need to have a theater available within 30 minutes on site. So in case there is a catastrophic rupture or there is a fetal distress, you need to be able to access delivery as soon as possible.
Thanks, Lihle. And then maybe I'll group these 2 questions where they're basically asking, it's I think Dr. Thabo Mateja and Sipogazi Siswana. They're asking how many times can we offer, is there a limit to say you've delivered successfully 1 VBAC, and then how many times can we try? Is there a limit?
There is absolutely no limit.
Yeah.
Maybe
there is no limit. So there are. Sorry.
No, continue, Doctor. Thanks.
Oh, okay. So there is a small study that showed that after you've had 2 VBACs, then the risk of uterine rupture tends to increase. However, it was one small study, underpowered. We cannot apply that to the general population. So with all the guidelines, you can VBAC as many times as you wish.
Maybe linked to that question, I saw people asking about the inter-pregnancy duration. Is there a specific duration or time between the first Caesar and VBAC?
Yes, so inter-pregnancy interval, there's been found that after 18 months from the birth to the next delivery is the ideal time that you can try VBAC. So unfortunately, if you have got a shorter pregnancy interval, your risk of cesarean, your risk of uterine rupture does tend to increase quite significantly. So 18 to 24 months is the ideal time where you can try VBAC.
Okay. Okay. All right, Billy, still there?
Yeah, there's quite a few interesting questions there, but I think one that we'll tackle now it's induction as well as augmentation in patients with previous seizures that are undergoing trial of labor. Your thoughts, your opinion on that, please, Lisa.
Again, there is no gospel, but there is no governing body that will back you if you use an oxytocin agent or a uterotonic agent and the woman ruptures, because part of the one of the major contraindications in these medications is if you have a previous uterine scar. So the American College guidelines does address this, that it must be discussed by a senior clinician with the patient and shared patient decision making. But I feel that that one is an unfair thing to place. It's an unfair burden to place on the patient because they don't understand the consequences of uterine rupture. So they say it's not, in America, it's not absolutely contraindicated. They said a senior clinician can make that decision. However, like I say, if you look at contraindications for use of any prostaglandin guidelines, if we look at the contraindication of use of oxytocin, having a uterine scar is one of the major contraindications. So you will have no leg to stand in court if you use oxytocin and the woman ruptures and yeah.
Awesome. I saw Dr. Valerie and I saw a lot of questions and comments.
I'm done. Can you hear me?
Yes, Doc. I was saying that I saw Dr. Valerie and I would have liked her to make a comment at least, because I saw a lot of questions around the high rates of cesarean sections. And I just want her to also make a comment on your presentation, but also to sort of emphasize one of the points she made around the importance of reducing the overall cesarean section rate. Dr. Valerie, on spot, my apologies for putting you on spot.
I hope my Wi-Fi connection hangs in there because both of us here at home are in meetings at this point. But thanks firstly, Liesje. Wonderful presentation, very nice, well presented, and it's nice to hear from you. We haven't seen
Hi,
it
Valerie.
in a long time. But yeah, the thing is, I'm all for VBAC, but you know, I didn't train here. So we induced VBACs, we augmented VBACs, and this was in Europe. And the success rate was very high. But the main issue, if we think about, you know, hemorrhage deaths, maternal deaths are one of the leading causes in our country, and we struggle to drop them. And it's not because of uterine ruptures and so on. It's literally because of the cesarean section bleeding during and after. So, and that has a lot to do with surgical skill. So if we want to reduce Caesar rates and complications thereof, I feel that tackling the primary Caesars, that is the main clue, and secondly, improving the skill. I feel that both in public and in private, we sort of miss the correct resources to do VBAC reliably. Like Liesje said, you need staffing, you need quick access to theater, but that's always doubtful. I feel like when you say, Liesje, it takes you 2 hours for emergency Caesars. Even if you don't have a previous Caesar, if you have a diaphyseal distress, 2 hours is a long time, you know. So I feel like we miss the resources a bit. But then on the other hand, and I think this comes back to my European background, if a patient is appropriately counseled on risks and benefits of elective repeat Caesar versus VBAC, she would actually go for VBAC if you think of the complication rate, because the rupture rate is actually low. But I think we somehow lack in counseling, but also an appropriate indication setting for the primary and the secondary Caesar. So I think those are just my points. But some people will definitely not agree with my opinions. Yeah, let me leave it there. Because it's a discussion that can go on for a very long time.
Yeah. Yeah.
Thanks, Valerie.
And maybe if you don't mind me asking Valerie as well, the induction using mechanical, I know that, I mean, as you just said, in the other countries, they do use, you know, induction methods, but in the South African context, mechanical induction, and maybe to actually ask two questions at the same time, up until when can we say we're giving an opportunity to go into natural labor? Up to what gestation? 41 weeks, 39, 40? And can we use mechanical in the South African context?
The thing is, you definitely can use a mechanical induction, because the mechanical induction is mostly prime the cervix. You know, it's not labor augmentation and so on. So I would definitely consider mechanical induction in someone who wants to try a VBAC or a trial of labor. The thing about the gestation is a tricky issue, because we know in women that even never had a previous cesarean section, that once you go beyond your 39, 40 weeks, that your chances of successful vaginal delivery start dropping, you know? So it's a tricky question. You know, I don't think there's an actual cutoff. We use 40 weeks. If you've reached your 40-week date, that's it. But then the question comes, in how many of our women, and I work public, do we actually have an accurate dating? So that's the other problem that comes into play there. So mechanical induction, yes. Oxytocin is something that, you know, the highest risk of rupture is with induction and augmentation of labor. The problem if you use prostaglandins is once they are in, they are in. Oxytocin is an effect that you can nicely titrate. You know, you're supposed to, every time you titrate up, you monitor the contractions. If there's hardly any contractions, the chances of her rupturing are lower, you know, and you titrate carefully up. You can use half dose and see. Because one question I also wanted to ask Lihle is, what about IUFDs, you know, patients with stillbirths and a previous scar at term or even preterm, and then the preterm labors. Are we going to do Caesars? Those are smaller babies, you know, so it's a tricky thing. And I think it always comes down to the patient's wishes. I had, at Calafong, a patient who had a previous cesarean section for CPD in a 3.2 kg baby. The next one was estimated 3.9, and she absolutely avoided a Caesar. And she delivered beautifully vaginally. So I think it's still, if the patient absolutely does not want to Caesar, we might have to induce them at one point. You know, it's still the patient's right to decline.
In fact, I was going to ask that now. Sorry, you just mentioned it. There's actually a question by Karabo. He's asked, it's a loaded question, but I think I'll tackle the second part of it. The issue of whether or not a patient can decline. I mean, I've worked in some different hospitals in my short career, where in one, we actually counsel her and she decides if she agrees. If she doesn't agree to a VBAC, we just do a Caesar. And then others that I've worked in Gauteng and perhaps this side as well in Mpumalanga, where we assess and we decide. She doesn't have to agree or disagree. We tell her that you are eligible and therefore we are not doing a Caesar for you. We'll just do a Caesar as an emergency. So the issue of the patient deciding whether or not she wants to have it, how do we address that? Is there any guidance, or it's all local protocols depending where one is?
No, I think patient autonomy overrules everything. If you've given her sufficient information, your role as a clinician is to continue to take care of the patient regardless of their wishes, obviously within reasonable limits of safety. I don't think we should force patients to do either or.
And then, Doc, if you look at 1829, Dr. Obed sort of is a question that maybe Valerie wanted to ask, but Obed is also asking, he's saying the management of a pregnant woman, previous Caesar times 1, 2, or 3 with an IUFD at 9 weeks or 18 weeks. I'm not sure if you can see the question and if you would like to make a comment on that. 1829 by Obed Contravele. Yes.
Q&A. Yeah. So yes. So basically, again, with the previous 1 or 2, you can use induction of labor, mechanical induction being your best option, using like any uterotonic agent. Like Valerie said, it depends on the type, it depends on your monitoring. It also depends on maternal wishes, because just because you are 18 weeks, it does not mean you are exempt from having a uterine rupture. Albeit it is much smaller than in a term pregnancy. However, uteruses do rupture in the second trimester as well. 9 weeks, we usually treat as any other uterus that has not had a scar. So we tend to use same doses of misoprostol than as if you have not had any cesarean scar.
Superb. Dr. Haruna, would you like to unmute and ask your question live? Dr.
All right.
Haruna?
Good evening, everyone. Good evening, the host. All right. My question is this. I would like to know, because of others too, in a 2 previous case of cesarean section, what is the clinical suggestion for normal delivery after 4 years of the last scar? So from the question, I see if there's any clinical chance of safe delivery. I actually want to know.
Okay.
So thank you for the question, Doc. So again, it depends on which guidelines you use. Americans say a previous Caesar ×2 can be safely tried, because again, the risk of rupture, unfortunately, it was not found to be significantly much increased to when you've had a previous single cesarean scar. So if you've had a previous single cesarean scar, it's like 0.7. After 2 Caesars was found to be 0.9. However, the rates differ in different countries. In some other countries, they found that it was much higher, up to 4%, and therefore we don't do trial of labor after 2 Caesars at all. So again, you counsel your patient with your resources, with what information you have, and you decide. But it is not, after 2 Caesars, it is not absolutely contraindicated.
Yeah, I see Dr. Obed is back again. If you look at 1832, he says we sometimes use Venofer or Cosmofer as an alternate to blood. Okay, I'm not sure if this question is relevant to today's topic, but it might be the issue of maybe in the context of trialing labor versus Caesar. Do religious beliefs have an influence, and how do you handle it? Maybe if now there's a need for a Caesar and you might not be able to use some of this. I don't know. I'm just turning the question to make it relevant. I think I was too quick to go to the question. Thanks, Doctor.
Okay, so I don't think I will also be able to answer that fully. But in terms of using Cosmofer, Venofer, obviously want your patient that we keep our patients on iron first of all through the entire pregnancy, to try and make sure that their hemoglobin levels are optimal before delivery. In the case of an emergency like a massive hemorrhage, Cosmofer and Venofer, they don't suffice. So I don't know if we can even apply it to this context.
Yep. Okay, Billy?
But I don't know of any alternative of platelets.
Sure.
Yeah. No, thanks for that, Lily. I'm always happy to see my local colleagues commenting. There's at 1836, Dr. Berry, one of the colleagues who've been practicing ops for some time. It's basically a comment that the local context here also makes it, actually he says, I'm a GP obstetrician in Nelspruit and Nelspruit at the local medical clinic, and he's been practicing for 40 years. He's the only one offering VBAC in Nelspruit and gets these requests frequently. So he assessed that patient selection is very key. He also still does clinical pelvimetry. And yeah, so what I just wanted to say on this comment is that, yeah, definitely, as Valerie said somewhere in one of her comments, that it seems like it's the public sector where it's possible to cut a Caesar in 30 minutes. I think the challenge is in both sides, for many of private hospitals, and perhaps one of the two or both here in Nelspruit as well, getting a Caesar in within 30 minutes can be a challenge. And I suppose it varies from between colleagues. Others would offer a VBAC like Dr. Perry, but many others would have reservations, based on their own assessment or their own protocols in terms of prerequisites for offering a VBAC. And it's quite interesting that the practice there in the Western Cape, where you are in Mitchell's Plain, is quite similar to what we are experiencing here. So yeah, there's quite a few, many other comments and questions. And I see Dr. Valerie is also asking me personally why I'm not offering VBAC, and I think I've answered that to say, if I have to wait for staff to come from Easy View so that I can cut a patient who's had a uterine rupture, I would rather just do a Caesar rather than offer them a VBAC. But yeah, I don't know. We still have about 9 more minutes. Do you want to go through some of the chat comments or questions, LS?
I want to give Dr. Mbula to tell us whether in Namibia is he practicing VBAC, and if not, why is that? Because my sense is that there's evidence-based medicine, and we need to try and move closer to that. And if there is a scenario under which VBAC is the recommended sort of option, why are we opting for an alternate intervention when science would recommend that? Maybe it's a nice discussion to have. Let's hear Dr. Mbula maybe comments on the talk, but you can also chip in based on your practice in Namibia. Thanks. David, your mic is not working. Hey, like last time. Okay.
Can I ask this one, MLS? It's quite an interesting question.
Yeah, David, try to rejoin. Thanks, brother.
Yeah. So as Lisa said, we do get those patients that really do not want to try for a normal delivery. And I try not to say natural because it makes a Caesar to be unnatural in a way. So it's at 1830 by Uzoma. He says, is it ethical or acceptable to do a Caesar for the reason of patient's choice due to convenience or dates? But perhaps to eliminate the last part, to say this patient really doesn't want to have a normal delivery for whatever reason. Is it ethical for us to do a Caesar? I know the medical aides will not agree with this in private, but does a woman have a choice to not have a normal delivery for whatever reason? Your thoughts on that, please, Lisa, or maybe even Valero, any of the other. Oh, I see Dr. Mdluli there as well. Perhaps you can also comment.
I think he had a comment, but he can just chip in. Thanks.
Sure.
Patient autonomy. So, like I said, at the end of the day, we respect patient autonomy, because one of the things is when a woman is in labor, I think we as obstetricians are just as stressed as probably the woman herself, because you can never fully guarantee that definitely this woman is going to have a successful, uneventful vaginal delivery. They can be distressed, they can be ruptured, they can be anything. So if a woman has come and has requested, and given that although the risk is small, but it can still happen, I do counsel her about other morbidities involved and the future and all those things. But at the end of the day, like I said, within reasonable limits, we do respect patient autonomy.
Awesome.
Dr. Welile, are you able to make your question or comments?
Yes. Good evening, Dr. Mawela, Billy, and Lise. Yes, I just wanted. Can you hear me?
Yes, we can hear you well.
Yes. No, I just wanted to raise the issue. Well, as much as we, Dr. Mawela raised the issue that we should encourage evidence-based medicine, we would like to go along those lines. But the one of the major problems that we're maybe avoiding in the topic is litigation. The obstetrics of fear. That's really a big issue there. Because should something go wrong, everybody forgets the books and they really go for the person. That's the comment I wanted to raise there.
Okay, Doc. Lisa, would you like to comment on that? Is that the real driver for practice in today's world?
I think it's a significant driver. It's not the only driver. It's a significant driver, though of rather erring on the side of caution than doing all things academic and finding yourself in hot water.
All right. Dr. Valerie, do you share the same sentiments? Because, all right. Yes, continue.
Maybe, oh yeah, I just wanted to bring maybe two questions. There's one from the Q&A and one from the chat, quite similar around the issue of sepsis. There's a colleague in KZN, I just can't recall the time and I can't see it now on my screen.
I think I'm watching it, 6:31.
Yeah. And somewhere on the other side on the chat where they basically talk about prevention of sepsis. Well, Tamsang, I think he was saying the colleagues are not giving antibiotics at the time of caesaer or afterwards. Not necessarily directly related to what we're talking about, but it's around caesars. Maybe I can just ask, how do we prevent, sepsis now that we are going to do or we've done this caesaer? Is there anything we can do to prevent wound sepsis or surgical site sepsis or infection?
So the only intervention that has been found to make a difference is basically the preoperative antibiotics. So a good dose of antibiotics within the hour of your skin incision has been found to make a significant difference in achieving or avoiding wound sepsis. However, I see he's talking about probably giving a course afterwards. I think that's more likely to treat the doctor than the patient. There's no evidence that has found that actually makes a difference.
Thank you. And then perhaps to also add that, where the dosage is for your morbidly obese patients, it's actually not 2 grams.
Not 2,
I know
it's 3.
Many colleagues are still giving 1 gram, but it should actually be a standard of 2, but the morbidly obese or the high BMI ones, it's 3. There's a question by Ngamsile there. She's asking, how common is spontaneous uterine rupture?
Quite uncommon.
Very uncommon. David has raised his hand. I think he's back.
Good evening, colleagues.
Good evening, David.
Alikle, thank you very much. David. Good evening. How are you?
Good. How are you?
Good to hear from you. Thank you very much for a very good presentation. Evening, Billy. Evening, Valerie, and everyone on the platform.
Evening.
Yes. Good to hear from you, colleagues. Yes. A very good talk and a very, I think, relevant topic, because I think these are the issues that we are faced with on daily clinical practice with the rising incidences of cesarean sections. So we are faced with these questions of patients coming to us, whether they can be offered the trial of labor after cesarean section. And I think everything was covered. I think I would probably just want to add to the discussion, and I don't think it's something new. And I think the key here is all about informed consent. And if we can really inform our patients very well, especially regarding the risks and the complications that are associated with each and every of the options in terms of the modes, whether it's a trial of labor or an elective cesarean section, I think it all boils down to a good informed consent, and then the patient makes an informed decision. But I think what is perhaps is important, and let's raise a point whether how we practice here in Namibia. Obviously, in state, yes, there's a few cases that we try to, that comes in, and we do offer a trial of labor after cesarean sections. Although even in state, I have my own personal opinion regarding trial of labor, especially with the morbidities that we have experienced. I prefer patients to come in advanced active labor. Those are the ones that I would really highly counsel to continue and go on with the trial of labor after cesarean sections. But those patients that comes in latent phase of labor, most of the time, those are the ones that often end up with complications. And I share the same sentiments with Litle. In private practice, I'm not a fan of a trial of labor after cesarean sections, and and mainly because of the multifactorial factors. I think Billy also highlighted them. The issue of trying to get a team on time in case a complication arises, you are most likely to end up with a catastrophe. And the situation is similar in terms of being called to labor ward that the patient is complicating, trying to mobilize anesthetists, pediatrics on time. It takes not less than 40 to an hour. So by the time you are called to salvage that to remedy that situation is often quite too late. And most of the time I'm honest to the patients about that, and I try to discourage them from trial of labor, especially in private practice, and also compounded by the issues of litigations, obviously. But the most reason is mainly the time factors of getting the team. But otherwise, I think the discussion was comprehensive, and the contributions that have been made were quite very, very informative. And I think it's really, it was a good discussion.
Yeah.
Thank you for the input, David.
Really? All right.
Awesome. Thanks, Dave, for those comments. You know, it's always nice to hear from you out there in Namibia, and I think we'd like to appreciate all the colleagues that have joined. Dr. Lihle, for really making us quite informed and engaging us. As you can see, it's quite a hot topic, and yeah, it's always nice to talk about scissors and all issues around cesarean sections. Thanks, Dr. Mdluli, for joining. Thanks, Valerie, for chipping in, and all the other colleagues that have shared their insights and their questions and comments. Yeah, looking forward to the next one, and I'll hand over to you, LS. Thank you.
Thank you, colleagues. I just want Dr. Lihle to say your closing remarks, and then we close the evening. Dr. Lihle?
No, just to thank everyone for spending the hour with us. Basically, what we have touched on is that trial of labor has much more benefits and safety compared to cesarean delivery. However, elective cesarean delivery is much safer than an emergency cesarean delivery. We have seen that with all those complications that we are talking about, elective cesarean delivery does have less complications than when you do trial of labor and then you have an emergency cesarean delivery. Also, mainly because of things that, like Valerie has touched on, the level of skill of the people that tend to do the scissors after hours, which are what most of our patients are exposed to in the public sector. It's the junior doctors, the junior anesthetists, it's everybody that's junior. So individualized care, and let's always just try and strive for evidence-based care for our patients. But yeah, that is all from me. Thank you.